Okay. All right, can everybody hear me? Yes. Yep, okay, good. So I'm probably going to remain seated, I think. So thank you very much, Teo. It's great to be here and to present at the Centre Rounds. So as the title implies, I'm going to talk today about addressing missed opportunities for HIV prevention and care among justice-involved youth. Just give me a second. Okay, so I'm going to provide a background about the overlap of justice involvement in the HIV epidemic in this country, with a focus on the context of HIV risk for justice-involved youth. I'm also going to explore community supervision settings as missed opportunities for HIV prevention. And then I'll end with a discussion of two interventions that I've developed with colleagues, many of here that are in this room, to address these missed opportunities and promote HIV prevention and linkage to treatment and care. And then finally, if we have time, we can wax philosophical about what we want to do next. But before I start, I just want to provide a very simple overview of the justice system, just so we're all on the same page here. It's much more complicated than this diagram would indicate. It varies across states. It's different in the adult and the juvenile justice systems. But essentially, for the purposes of this presentation, if you can conceive of the justice system as basically comprising three different parts, and the first, do I have a pointer? Yeah. So the first piece of it is community supervision, and as the name implies, that is justice involvement for folks who remain in the community, so they're not in locked facilities. This includes things like probation, parole, supervised release, so while you're waiting for your court date, and alternatives to incarceration and detention programs. Then we move into jail and detention. This is a locked facility. This is typically a shorter term stay, and you can be in jail or detention either before your sentence or your court hearing, or after as a result of your sentence. And then finally, we have prison. And that is, again, a locked facility and typically characterized by longer stays or longer sentences. In the juvenile system, we call it placement. I think it's because we all feel a little bit squeamish if we talk about sending 15-year-olds to prison, so we call it placement. But this is typically a longer stay, and it happens after court. And then the court is really at the fulcrum of this system, as it directs traffic as to where people go, whether they remain in the community or they go further in deeper into the system. And then obviously it's all very interrelated. So these arrows indicate that you can exit the system at any of these points. However, it's a bit of a Hotel California. You can check out, but you can never really leave. About 2/3 of those who are incarcerated will recidivate and end up back involved in the justice system once they're released. And largely that is because after release, typically you would go back under community supervision, and that would be parole. And so you have orders and conditions of your parole, things that you must adhere to while you're in the community. And if you don't, then the chances are you can go back into the locked facilities. So just some information. 1 in 37 U.S. residents are currently under supervision by the correctional system. I mean, that is huge. It has broad, far reach in this country. And we are the lead of industrialized nations when it comes to incarcerating our people. We share that honor with countries like Cuba, El Salvador, and Thailand. We also incarcerate with considerable disparity. 1 in 3 African-American males will be incarcerated in their lifetime. Currently, about 2/3 of those who are incarcerated in either the adult or the juvenile system are either African-American or Hispanic, despite the fact that these individuals make up 30% of our population. So here we have, let's talk a little bit about the overlap of HIV and justice involvement. Here we've got two maps of New York City. On the left, you have rates of jail incarceration by various neighborhoods. And then on the right, you have rates of new HIV diagnoses. And if you look here, you can see that those areas that are deeper red indicating a higher burden of either incarceration or HIV largely overlap. And these are also areas in this city that are largely poor neighborhoods, and the residents comprise are largely comprised of minorities. And that is the population that carries both the burden of HIV and incarceration in this country. And New York is no exception. Across the United States, we find rates of HIV infection are 2 to 5 times higher in justice populations compared to the general population. About 1 in 7 HIV-infected Americans passes through the correctional system each year, and the flip is also true. Recent data from the Adolescent Trials Network found that a third of HIV-positive youth had prior justice involvement. And data from CASA Claude study, we found that perinatally HIV-infected had arrest rates that were 4 to 5 times higher than general population youth. So let's look at the context of risk specifically for youth, for justice-involved youth. As we've noted, they're living in neighborhoods that are characterized by poverty, high rates of crime, violence, and high community viral load. Yet there are additional risks that are present in these other interconnecting systems in which these youth reside. For example, in the family, work that I've done as well as others have shown that families of justice-involved youth are characterized by greater conflict, less support and monitoring, poorer communication. Similarly, peer networks can be characterized by those that are largely antisocial, and often a high-risk pool of sexual partners if you're residing in a community that has high viral load. School system is a huge risk factor. You see school dropout anywhere from 2 to 8 times among the justice population, greater than general population youth, and rates of unemployment for 18 to 24-year-olds are similarly elevated. And the youth themselves are managing considerable mental health and substance use disorders. Rates have found anywhere between 30 to 75% have a disorder, so not just sort of clinical problems, and about 50% have both. We also have significantly high rates of trauma exposure. In one of the studies that I'm going to talk about later, we are capturing trauma experiences, and one of the things we had to do was amend our trauma instrument. It was not sufficient to capture the number and the depth of trauma experiences that these youth had experienced, and that was a sobering day. And so in other populations as well as in this, all these risk factors confer to increased rates of HIV risk behavior. And myself and colleagues have demonstrated time and time again that this population engaged in considerable rates of risk behaviors. One study found that 66% had engaged in 10 or more risk behaviors in the past 3 months. And typically we're seeing earlier sexual debut, multiple partners, higher rates of sex while intoxicated, lower condom use, and then greater rates of sexually transmitted infections. But despite this risk, evidence suggests that justice-involved youth are not accessing HIV services as we would like them to. I don't think I need to describe treatment as prevention to this group, but briefly, the idea that we can treat ourselves sort of out of the epidemic, reducing community viral load and stopping new infections by moving folks through those stages of the HIV care cascade. So screening and identification of HIV is then followed by linkage and engagement in treatment and care, and then ultimately with retention in care and leading to viral load suppression. There's not much data out there, but what there is suggests that testing, which is the initial and necessary first step of the cascade, is not being adequately accessed by justice-involved youth. A study of youth on probation, ages 12 to 18, found that 22% reported a lifetime test. And then 59% of youth in my own work of 18 to 24-year-olds, justice-involved youth, reported a lifetime test. So if you think about the context in which these youth are living, these rates are incredibly low. But just to plug here, we're also not doing great with youth in general. These are general population rates. African-American and Hispanic youth typically have higher rates of HIV testing than their white counterparts. However, it's still low. Between 67 and 83% of school-age youth and 40 to 73% of young adults have never had an HIV test. So I think in general, there's work to be done there. So as these youth reside in high-risk contexts, they're becoming increasingly disconnected from family, school, employment, and other social institutions and structured activities that can confer protection. And as a result, they're becoming more and more disconnected from treatment and care systems. And the result of this is that we are not able to find these youth in the community and link them to care. However, where we can find them is in the justice system. So, but we're possibly missing opportunities here in the justice system. So community supervision agencies. So if you think back to that figure that I started with, that's the portion that's on the very left side. They're potentially ideal places to intervene for these youth. So first of all, the bulk of those who are in justice involved are under community supervision. So working in community supervision agencies, you are going to be accessing a large amount of the justice involved population. And as I mentioned, it's a great place for us to be able to identify access these high-risk youth that otherwise in the community we can't find. And then we'd be able to provide and link these youth to prevention and care in the community. Now, there's a constitutional mandate that translates to care and services being offered in locked facilities, so in prisons and jails. Now, we can debate the quality of that care at another time, but it is there. However, there is no mandate to provide such services in the community. So are community supervision agencies offering these services? So myself and a few colleagues, including Ralph De Clemente, we conducted a series of studies to really explore and answer this question. We wanted to know what, if anything, HIV services were being offered in community supervision agencies for youth, explore organizational factors that influence these practices around HIV services, and then determine what are potential intervention strategies. And the data are drawn from JJ Trials and my K Award. So let me explain what JJ Trials is. Some of you may have heard me talk about it before. It was a NIDA-funded, or is still, a NIDA-funded cooperative comprising 6 research centers and a coordinating center, and these are they right here. So Pennsylvania, New York, Kentucky, Florida, Georgia, Mississippi, and Texas, and then our coordinating center was in Illinois. Each research center, they were universities, were tasked with bringing a justice partner to the table, and a state-level justice partner from 7 states, and so we included Florida there as well. And within that, there were about 36 counties were included across all 7 states. The primary goals of trials were to provide insight into what is currently going on with respect to substance use in HIV in community supervision agencies across the country, and then to improve delivery and access to evidence-based practices that address risk behaviors associated with substance use and HIV. And there were 2 separate study protocols. So the survey, as I mentioned, it was developed to really assess the current state, the lay of the land. The survey was administered to community supervision agency directors of agencies that serve juveniles. And we had a nationally representative sample of 20 states. And within each state, a representative sample of about anywhere between 8 to 14 counties were selected, and for a total of 195 counties. The data were then weighted to reflect the national number of community supervision agencies and the youth they serve, which is just over 750,000. So the first question, are they providing services? We asked whether or not these agencies were providing any kind of HIV-related services, whether it be on-site or via referral off-site in the community. And the bottom line is no, they're not. About 75% of these agencies were offering nothing. Those that did, primarily on-site services, were focused around HIV or injection drug use behavior risk screening, so that's not testing. And then off-site tended to be referrals for more in-depth assessment and HIV prevention and treatment. We asked the agency if they knew where to find these services in their communities. And so for the majority of these counties, these services were available, but consistently about a quarter of the agencies had no idea where to find HIV-related testing prevention or testing for other infectious disease services in their communities. And then to really just drive this point home, we asked them to rank 17 of their training and technical assistance priorities. You can see the top 5 are those related to mental health, substance use, adolescent development. Training and evidence-based prevention and treatment for HIV risk behaviors was almost dead last. That was rejection, was a bit stinging. And so 17 was something, I knew somebody was going to ask me that. I think it was something really mundane about like logistics on site. Had nothing to do with anything. It was really, we were at the bottom of the barrel. So then we wanted to explore a little bit more some of the contextual elements around these agencies and specifically what were staff attitudes about providing or not providing services. And so as part of the main JJ Trials study, we collected staff survey information from across 36 different sites. So it was about 500 juvenile justice staff, the majority of whom were probation officers. And we wanted to explore, we asked them about their perceived importance of providing various services and how they saw it as a key part of their role. And we asked them about mental health, substance use, and HIV. And so we asked them a slew of questions about how the importance of HIV prevention. And so it was, the responses were on a scale of 1 to 5, 5 being strongly agree. And here you can see sort of, on average, they thought that providing HIV and STI prevention and education to youth on their caseloads was reasonably important, and then they agreed with that. However, when we asked them about testing, here you can see that they actually did not agree that this was necessarily important or particularly part of their role. And I want to draw your attention to these two items. When you see the word service plan in community supervision, it's almost like a treatment plan. So the probation officers or the agency staff, they create a plan, and this is something that they're going to work with the youth, and this either includes their orders of probation, the conditions of probation from the court, or other things that based on the assessments they think that it's important for these youth to do. If they don't do it, then they continue to get into further trouble. And having HIV testing as part of the service plan was absolutely not something that they thought was necessary. But then when we go back to treatment, they did agree that it was important to link those youth who are HIV positive to treatment. However, they didn't agree as strongly with that as they did to provide prevention, generally speaking. And what we also, so I mentioned that we asked them their importance of across different services, mental health, substance use, HIV. And so here we can compare their perceptions of importance around prevention, screening, testing, and linkage, HIV in blue versus substance use. And across the board, this indicates significant differences. They conceived of substance use as far more important than HIV, providing those services. And so, and then this made me think about some of the information that I'd gathered during my K Award, which I did before all this. But so for those of you that don't know, my K Award was to develop a family-based HIV prevention program for youth on probation. And to do that, I conducted formative work with the population I was working with, which included probation officers. And so I conducted a few in-depth interviews, and I wanted to, first of all, understand if they recognize and address sexual risk in the youth that they see, and what is how they perceive their role in doing anything about it. They did recognize risk in this population, absolutely. But it wasn't particularly part of the conversation unless it was part of the charge. So it was the reason why they were there, the legal reason. This is probably my favorite quote. It's not on the form, so we don't ask. I figure if it's not on the paperwork, it's not something for me to just initiate asking about kids. And then staff noted feeling uncomfortable and unprepared to discuss sex with youth on their caseload. I don't know if we're trained for it, talking to youth about sex, that is. It's kind of like we're trained to de-escalate and educate, but I don't know if we're necessarily trained for this. And then finally, I think this quote really sums up with the struggle that POs articulated to reconcile their role of probation officers with their responsibility of providing youth with these HIV services. I mean, I know they're all having sex, and I mean, I do know some that are pregnant, and I do know some that have STDs, but I don't know. There's just so much more besides that. I mean, in a kid's orders and conditions of probation, there's nothing in them that says you can't have sex, or that you have to have safe sex, or that you can't get pregnant. So that's almost like an extra that we're not even court ordered to address. It's kind of something that would be on the back burner. And having worked with probation officers and knowing what they do day in and day out, I absolutely empathize with this. I can see that they have their plates full, and this is one more thing that they just do not feel like they can adequately address. And so they don't. So what do we find with respect to HIV service delivery and community supervision agencies? I think we can safely say it's not on the form. It's not being done. They know that their youth could benefit from prevention and education and other HIV-related services, but it is just not something that's perceived as a relevant part of their role. Unprotected sex is not on the causal pathway to recidivism. There is probably a stack of literature as tall as me that has identified the link between substance use, mental health, and recidivism, and particularly the treatment thereof and the reduction in recidivism. That's not the case with sexual risk behavior. It's correlated, sure, but not necessarily a causal pathway. And so understandably, they don't focus on it. They don't have a focus on public health, but really on public safety. And so as a result of that, HIV services just either on-site or indirectly are not provided. So we need multi-level interventions, basically thinking about how to intervene and address this issue and increase access to HIV prevention and related services for these youth. We need services that are not just going to target youth risk behavior, which surely, as I demonstrated, definitely needs to happen, but we also need to target the justice system itself. And so I'm going to now describe 2 interventions that I've developed with colleagues to do just that. So we can have public health and public safety is kind of what I want to convey here. So probation officers or community supervision agency staff, they're telling us they're not trained to provide HIV and prevention services. They don't know a lot about HIV and where services in the community. They're not comfortable doing these things, and they don't see it as a key or relevant part of their job, which is probably the most important. Yet there's a whole slew of other staff in a whole other system that they are trained to do these things, that they have considerable knowledge about HIV. They have considerable expertise and practice in engaging hard to reach, difficult youth populations. They're comfortable in doing so. And yes, it is a substantial, if not a key or significant part of their role. So maybe a solution, a possible approach to intervention here is to really generate partnerships between justice and health systems so that together these 2 systems can work to identify, intervene, and then treat youth as these high-risk youth as necessary. So let's start with the JJ Trials HIV protocol. And this was done by myself, Ralph DiClemente, and Stephen Belenko. And the goal of this was to establish a partnership between juvenile community supervision and local health agencies. And we assigned them a task of creating a practice improvement goal that would in some way increase their HIV and STI testing in youth on their caseloads. We did not specify what that goal could be. It was really up for them to decide and define. And it would be broadly defined as well. And then we wanted to do this we explored the use of a local change team and external facilitation as a way of establishing and forging this partnership. And then finally, we examined the feasibility and acceptability and the potential for sustainability of doing so. So just so we're all on the same page, a brief review. Local change teams are those that are, they're teams of individuals within an organization, or in this case, across organizations that have been tasked to improve a given organizational practice. This has been well-suited, shown to be well-suited for implementation of cross-system programming, where potentially cultures, approaches to collaboration, priorities, and even general role ambiguity can hamper collaboration. And there's been demonstrated efficacy of this approach in adult settings, but it's not been tried in the juvenile system. And so we used external facilitators as a way to kind of essentially grease the wheels, if you will, of the local change team. An external facilitator is someone who often possesses either additional or deeper knowledge related to either the change that is being implemented or the process of change. So sort of, you think logistically, how to achieve change within an organization.
Are you going to talk about like a concrete or where you get them from?
So external facilitators. So in this instance, they were provided by the research study. So that was the research team. But in other situations I can talk about at the end, there are people in the community that you can draw from that have this expertise. And so this was taken, again, we worked with in 6 different states, and we had to find a new county, so not those that were involved in the substance use protocol. So these were new counties, and we had 6 different counties across the 6 states of JJ Trials that were engaged in this. And so this is an outline of the design. So first of all, we wanted to establish that partnership and form the local change team. We then engaged in training of the local change team and assisted them with their goal selection. What were they going to do? And also with facilitation, work with them to develop a program or a protocol around their given practice change, and then ultimately roll out that protocol and train additional staff at the agency as necessary. So let's talk about partnerships, because it was not an insignificant challenge. We, on average, across the 6 research centers, we had to approach about 3 justice partners and 2 health partners in order to find folks within a given county that would agree to do this. You can see here that in Pennsylvania, they were unable to do that. They could not find a justice partner that was willing to participate. Typically for justice partners, it was a lack of interest. Again, they did not see this as a priority, or lack of time. And for health partners, primarily the reason that they weren't able to participate was lack of resources, that they couldn't necessarily afford the additional staff time. So we began with goal selection training. It was a one session. It lasted 3 hours. This was a very compact and efficient intervention. The training curriculum was really, as the facilitator assisted the change team in identifying a goal that was going to promote testing in some way, and then go through the steps needed to accomplish this goal and to create an action plan. So here, this is an example of an action plan. So here is the goal. You can see right up here what they wanted to do, and then we break it down into a series of steps. So first, they needed to understand how they were going to address the importance of HIV testing with their youth and who they were going to offer testing to. There's within youth under community supervision, there are various classes of youth, and they come through the system in different ways. And so it's important to think through from a sort of workflow perspective how you're going to access these various individuals. And then obviously you break this step down into tasks and who's going to accomplish them. And so there are numerous steps for each goal. So the local change teams met to after the training, an average of about 2.5, 3 times to complete their action plans. There were about 6 people in a local change team, and of which 20% were the health staff. So they really did work together on this. With the facilitators, which was identified as a real key part of this process, they had a total of 12 contacts. So that would have been in-person, emails, or phone contacts to get their assistance. And we found, and we were able to have, so all 5 of the sites, so obviously one dropped out. Pennsylvania was not able to gather partners. Of the remaining 5, all of them developed a protocol, but only 4 were actually able to implement that protocol. And that was due to the fact that they couldn't get a memorandum of understanding signed between the county health and the county probation department. It got held up in the county attorney's office, and it timed out by the time the study was over. They just weren't able to do it within the time frame we were looking at. So that's not an insignificant thing to think through when you're doing this sort of work at this level. The programs they all ran for 12 weeks, but at the end of the study period, they were all continuing on. So sustainability would seem to be a solid option here. 3 counties implemented on-site HIV testing programs, and they were administered by the health partner staff. And then 1 county wanted to develop an education and referral program, and that was delivered by probation officers. I should say that of each of these counties, none of them were offering any kind of HIV prevention or related programming at all. So this was brand new for them. So the baseline measurement was 0. However, if you look now at for the on-site testing counties, 98% of youth that came through these agencies during that period of time were offered an HIV and STI test, which is just tremendous if you go from 0 to that. 70% were assessed at being particularly high risk. Of those offered a test, 41% accepted. And again, we're seeing this low test rate of acceptance. And I do think that's an area we can continue to work on. What is it that we can do to really get these youth to take a test? We found no one that was HIV positive, but 43% had an STI, which was incredibly, incredibly high. And then with the program, the site that just delivered on-site education and prevention, they were able to do that with 100% of the youth that came in through intake during that period of time. So it was successful, and we were able to get services delivered in these settings. So then I want to talk about Move Up. So this is the program that the staff here are all part of. This is taking place right now in the Brooklyn Criminal Courthouse. And the goal here is to establish partnership, again, between justice and local health agencies. There's a theme here. And we wanted to develop and test the efficacy of a program that is designed to reduce risk and promote health. And that is accomplished by offering HIV and STI testing and screening, engaging the youth in a brief one-on-one intervention to reduce risk behaviors and to promote service readiness, and then obviously to link youth to substance use and sexual health services as necessary. So we brought together 2 partners in this project, and I just want to give a shout out to Renee and Alcohol from Project Stay, who are the best partners. a girl could ask for. They are absolutely phenomenal. They run Project Stay, which for those of you that don't know is a comprehensive program that delivers clinical services for youth living with or at risk for HIV. It's affiliated with Presbyterian, but it is based in the community. And they also have a strong venue-based outreach and engagement program where they go around various community settings and engage youth in HIV testing. And then we worked with the Justice Partners. So the Center for Court Innovation, as the name probably implies, is an NGO that really is tasked with creating and implementing better programs within the court system itself. And one of those is the Brooklyn Justice Initiatives, which is an alternative to sentencing program that's run out of the Brooklyn Criminal Court. And essentially what that is rather, as the name I suppose implies, in lieu of being sentenced, the youth agree to attend the Brooklyn Justice Initiatives program instead, and they're mandated to attend for a certain number of sessions and receive a specific number or type of services. So Project Stay had been working with the Center for Court Innovation for a while prior to the beginning of our particular project, but this was the Center for Court Innovation has numerous projects and programs around the city, but this was the first time that they had worked with BJI. And it's located in the courthouse, so the youth, they go to their court part on the 8th floor, and then they come down to BJI on the 3rd floor. So it's a one-stop shop. And the Move Up is essentially an integration of existing evidence-based practice. So a brief HIV and STI risk assessment, New York Expert, which was developed in collaboration with Northwell Health and what is now the Center of Addiction, which was formerly CASA. And that's an evidence-based screening, brief intervention, and referral to treatment program for substance use. And then MOVE, which is an evidence-based program developed by Patrick Wilson. It was designed for African-American HIV positive men who have sex with men, and it was to promote their health and engagement in treatment. And this may seem like a funny intervention to pull for justice-involved youth, but I'm going to get to it in a second, who are largely heterosexual. This uses a framework called critical consciousness, and it was really important for this population, and it lands very well. I'll talk about that in a minute. For those of you who are interested, in case I don't get to this, we have a website. Check it out. Our intervention is all online. We're trying to be as paperless as possible at the courthouse. We're trying to have a very small footstep because we have next to no room, and we spend a lot of time outside on the corridors on court benches. And the work has been delivered by Project Stay health coaches. So again, when the intervention is being implemented in a conference room at the Brooklyn Justice Initiatives, it is Project Stay staff who are doing it. And so the intervention that we created in partnership with Stay staff, with BJI staff, with Youth Advisory Board, we ended up with a 4-session intervention. The first is a one-on-one, and they meet with a health coach, a Stay health coach. And there we really drill down and do a very personalized substance use and sexual health risk assessment. That's when testing is offered. And we engage in a brief negotiated interview, which is a motivational interviewing based approach to really having someone examine their substance use and think through where the problems may be and where and how they might want to change that behavior. And then at the end of it, we work with them to create 2 action plans, one that is focused on their sexual risk reduction and another that is looking at their substance use behaviors. That is then texted to the youth, and they get it on their phone, and we send them periodic reminders as an encouragement to continue to work on their action plans throughout the remainder of the intervention. And we begin with, if we have time, I'll show you it. We begin with a health pitch video at the very beginning to kind of get the youth engaged and sort of excited about what it is that we're going to offer them. Then session 2 is probably the meat and potatoes of this intervention, and really what resonates with the youth. So it uses critical consciousness to promote healthy behavior. So for those of you that don't know, critical consciousness is the process of becoming aware of the forces in society and that oppress people. It's based from Paulo Freire's theory of oppression. And essentially what it's saying is that there are oppressive forces in society that influence an individual, and there are events that relate to that and resulting feelings of powerlessness, despair, which can in turn influence how we behave. And in this instance, we're looking at substance use and sexual risk behaviors. Where critical consciousness comes in is that it really allows an individual to become aware of what these oppressive factors are, how they're shaping their life, and we give them tools and really empower them to rethink what that might be and what that can look like, and to engage in healthy behaviors. And we do that via analysis. In this particular program, we do it via analysis of media. And so I'll show you some examples in a second, but we go through an exercise where we have them look at whatever the example of media is that we're looking at. Let me see, what is it that you see? What do you hear? What do you think the meaning of the message is? What do you think of that message? How does it make you feel? And so really kind of, again, bringing that critical consciousness to bear. And then the important step, the last step, and the hardest step is what can you do about it? And we have discussions about what they can do at the community level with family and friends, and also with their own self, their personal level. So this is some of the media, examples of media that we use. I think this one is particularly compelling. It's not a great image, so I apologize. But here, this is, so you can't see, but this is the same, it's a website, the same news agency, the same day, and the same author. And I want you to look on the left. 3 University of Iowa wrestlers are arrested, burglary charges pending. They're all in their suits, and this is a question mark. They might not have done it. Here on the right side, you've got the police arrest 4 in burglary investigation. This is, they're guilty, and these are mugshots. And it is subtle and it is insidious, but it is all around us. And so we start thinking about how do those things influence the way that you see yourself, and how does it make you feel? These are other examples. This is it's cut off, sorry. This is a PSA, if you will, to not drink and drive. And it says here, he'd love to meet you. And this is an African-American gentleman in a prison jumpsuit, looking very menacing. This is a huge advertising fail for Intel. We call this the bow down ad, where you have a white man in the middle, and they're talking about optimizing the power of their employees, but their employees are all African-American males that are bowing down, and they're supposed to be in a running stance getting ready to go, but I mean, no, that's not what it is. And then this one as well, Dove, a summer glow. It's for one of those like tanning, I think, or moisturizing creams. Nourishing lotion for normal to dark skin. I don't know what normal is, but apparently, according to Dove, it isn't dark. And then this one as well, we talk about, for an example, the Vogue cover that many of you probably remember, with LeBron James and Gisele Bündchen. And this was taken by Annie Leibovitz. It was very controversial at the time, and obviously it's a retake on this particular First World War advertisement. And so we talk about this. And initially, this is not necessarily something that they think they have a problem with. When the youth just look at this, they don't see that it's a negative image. And when we compare it to this, it really starts, the conversations really begin to take off. And then sessions 3 and 4, there we focus on sexual risk and substance use, risk reduction, thinking about treatment, what it is, what it isn't. And then in session 4, we really focus on how to manage stress and problem solving. These youth articulate they experience a lot of stress in their life. They absolutely do. And so it's important to give them some tools to manage that. And also improve social supports and communication, which unfortunately is sadly lacking for many of them. Again, as I mentioned, the Stay Health coaches are integral throughout the entire process here. They facilitate the group sessions 2 through 4, as well as deliver the one-on-one session. And linkage happens throughout. So we identify needs for substance use and sexual health treatment during session 1, and sometimes it emerges during the group sessions as well. And so the health coaches continue to work with the youth throughout the 4 sessions. They're working in the background, and they are absolutely phenomenal. The dedication to this role is tremendous. They're constantly texting. Rarely do we call, but constantly texting with these youth, checking in, seeing how they're doing, if they're working on their action plans, and nudging them along to treatment. A lot of them are not interested, don't think that it's necessary. There are some that really do want treatment, and so we're working that balance to try and link these youth to care. What is great is that because these are Stay Health coaches, because they work at Stay, when it comes to sexual health, it is a super, super easy link we just send them right up there. And for those who don't necessarily want to travel all the way up to Harlem, Washington Heights from Brooklyn, there are many that do, but for those that don't, Renee and Al are so plugged in the network in the city that we're very easy to find sort of piping hot referrals in Brooklyn. And so we've been pretty successful there. So we ran a pilot. So currently Move Up it's running in the courthouse. We're doing an RCT of the intervention. So I don't have data to show per se, but just of the pilot test we did before we started, we enrolled 21 youth, 20 of whom came to at least one session, and half of those attended sessions 2, 3, 4. About half engaged in unprotected sex in the past 3 months. We've actually changed the way that we ask that question, and now the rates are a little bit higher. Almost 80% smoke marijuana daily. That's changed over the past couple of years. And to begin with, when we were working to develop the program, it was just dealing with, about 3 years ago, alcohol and marijuana were primarily what we were seeing. Now we actually are seeing a lot more opioid use in this population. It's creeping up to about 25 to 30% that we're seeing now. So the rates, we used the audit and the DAST in the session 1 to assess their alcohol and their substance use problems. Alcohol was low risk on average and the DAST was moderate. That's a lot of underreporting. The DAST really does not adequately capture problematic substance use with these youth. It just doesn't. It's going to be a really interesting paper. All of the HIV tests were negative. We did find 3 that were positive for STIs, and we were able to successfully link all 3 of them to treatment. And so, in average, in the main, the youth really thought the program was great. They enjoyed it. They didn't have any suggestions for change. They wanted to make it longer. However, when we try and get them in for 4 sessions at the beginning, they're like, it's too long. And we ran a quick focus group at the end of it, and the participants stated that session 1 was really helpful in motivating for them to really identify risks. And the participants stated that their favorite part of the groups was that session 2, where they start talking about oppression in society. So in summary, we know that these youth are at risk for HIV, but considerable gaps exist in their access to and use of HIV services. So continuing to develop these programs is important. But it's also imperative that programs be adopted and integrated and sustained by the justice system. But because these youth are so often lost to the healthcare system in the community. And I think we've demonstrated that community supervision agencies can serve as a critical point of intervention and delivery of HIV-related services. We can have a balance of public health and public safety. And we can do that by developing real, honest partnerships between health and justice systems that can address these system-level barriers to service delivery. And one of the ways that we found we're able to do that is by expanding the workforce. So rather than asking community supervision agency staff to do something that they don't feel like they can do and they don't necessarily see it as their role, bring in the staff from a system for whom that absolutely is their role and it is their goal. Where to now? So I have experienced some roadblocks with finding funding for continuing to doing this work, in large part because of the low rates of HIV infection in this population. And absolutely, funding needs to go to those populations who are, where rates of HIV infection are highest. But I think I've demonstrated here that lack of HIV infection does not mean to say that they're not at significant risk. There are substantially high rates of STI infection. There are high rates of HIV risk behaviors. The context in which they live further increases this risk. Do we just want to wait until these youth become HIV positive? Is that what we want to do? Or do we want to prevent that from happening now? Do we want to instill positive and healthy behaviors, sort of consistent testing behaviors in these youth? Interventions that, and I say yes, clearly, interventions to promote cross-system collaboration that can facilitate the identification of these youth and their referral and linkage to treatment are critical. And implementation science can really help us identify some of the best strategies for increasing the adoption of these programs, local change teams and external facilitators being one of those strategies that works. And then we can also expand this model to other health-related behaviors. It doesn't just have to focus on HIV in this population. There's a project that I'm running with Gail Wasserman called eConnect. And that project is to identify suicide and related behavioral health problems in youth on probation in 10 counties in New York State. And what we've done is essentially we had county in each of these counties, we had county mental health and county probation come together and basically agree upon specific referral pathways for these youth. So there were 3 classifications of risk with related to suicide, and they worked out where each classification would go, what agency would take them, and how they would get there. Are we calling 911? Is mobile crisis coming? And it's very, very clearly laid out. And the commitment from mental health to do that, or behavioral health, was critical, because in a lot of instances, there's a lot of stigma on the behavioral health side of things to working with justice-involved youth. And so a lot of times it's hard for these youth to get into treatment. They don't want to be treated, and their cases are very quickly closed. And so we got the commitment of the health systems in each of these counties to really work with us. And what we ended up doing, and thinking back to, if you remember, the JJ Trials HIV protocol, a lot of health agencies said they want to do this, they don't have the staff. They can't really have the staff to come on site and do this. So this is what Gail calls a clinician in a box. We created an app. And essentially what it does is the youth completes the behavioral health screener on the app. They hand it the tablet. They hand the tablet to the probation officer who scores it. And then what happens is the scores identify specific risk classifications. And on the app, it tells the probation officer exactly what to do, where to send the youth, who to call, and how to do it. We then press print, and there's a referral form that comes out, and this is sent on to the providers. And so we're about to go into the field right now and do that. I'm going to go a whistle-stop tour of New York State and 10 counties and teach the probation officers how to use the tool. But again, this is bringing the 2 systems together in a way to really effectively identify these youth and get them to the services that they need. And with technology, we can hopefully do this in more efficient and cost-effective ways. And I just want to acknowledge the team for Move Up. So this is a NIDA-funded project. Tisha Wiley is the project officer. And this is the team that's involved in sort of daily work at the courthouse. It is immense. This work is tremendous and fulfilling work, but it is hard. It is hard to do, and it takes a lot of people. And so I just want to give a massive shout out to my crack squad. They are tremendous. And particularly I want to highlight Jillian Watkins, for whom my project director, for whom none of this would happen. And then also Bobby Hickson, who's at the courthouse every day. He's our field coordinator, tracking these youth in the field, and again, it's absolutely tremendous, so thank you. And then there were also way too many people to list on the JJ trial, so I just list the universities that were involved. Thank you.
Wow. It was amazing. Your first paper was just about the youth, and after that you conquered the whole system and the health system.
Yeah.
It's really amazing. And of course, when you don't need Jillian anymore, there are not a lot of people who want to take her, so you can't do it. This is amazing, and I assume that there are questions or comments.
I have a question. So you have your intervention is 4 sessions, but I feel like you take on a lot and a lot of kind of meaty topics, and I was I know there's a lot of tension between, wanting interventions to be really fast because that's what participants want at the outset, and people want really quick fixes, and then there are really complicated things that you're trying to address. And so I actually really liked, it almost sounded like the intervention was intended to kind of pique their interest and to make them aware of the problems, and then the real work happens when you're linking them to their communities. I just was wondering.
Yeah.
I think that's a sustainable model for others.
Yeah. So the sessions themselves are each 3 hours long. So we're able to pack, well, for the most part, we don't always start on time. So we're able to pack a lot into the 3 hours. So it's 12 hours of intervention, if you will. But yeah, it has to be short. They're not there very long. And then once they're out of BJI, they don't want to come back to the courthouse to continue programming. Obviously, I wouldn't either. So that was by design. But yeah, we use we have the one-on-one session to really kind of grab them and then engage with them and have the linkage piece going on in the background for that very reason, that it would be hard to expect that in 4 sessions we would be able to accomplish that without that intensive linkage going on in the background. But it is attention. I wish it could be longer. It probably should be.
So I cannot help myself but say I'm a minor part of this project, but I have been so wowed by the work that Kate and the team and Alan and Renee have done. And those of us who helped develop it in the pilot work, every single time we went to a session with young people, we all had this little love fest afterwards. I felt so inspired by the vibe in the room and the participation of the people. There is a substantive thing I want to say, which is that Project Stay and MUFA both give, and I'd love for you to comment on this, unexpressed intervention to get to the point where they are part of the court system, the juvenile justice system. So there's a whole other piece of you working for months, maybe years,
Right.
to be trusted and known and really be part of the family. So I thought maybe you could talk about how that happened.
Well, yeah, I mean, I'll just speak generally, and then maybe Alan, Renee, if you want to, you can speak more specifically. But I think that we talk about the partnerships that we have to have, community partnerships to do the work we do. It's like the partnerships are a function so that we can do the work we do. And my experience over time has shifted that. The partnerships are the first step in the work. And the more engaged these partnerships are, sort of my earlier project, my K, I had this idea. I had partners at probation who basically said, yes, you can do it here, and that was it. And it was very separate. And now it's changed where we really want to have the partners that are involved. They're at the table. They're working with us, and they're actually delivering the programming. It's not researchers that are going in there and doing it. And it's really important. And it takes time to develop these partnerships. It really does. But Alan, Renee, you guys have been working with the Center for Court and Innovation, but then other justice-involved programs across New York. So do you want to speak a little bit about your experiences establishing these partnerships?
Yeah, I would just echo that. It does take time. So as Kate mentioned, we have a brick and mortars clinic here at the Presbyterian Hospital. We do services for HIV positive youth, and Joanna Fields, our faculty social worker, who anchors that program. But in conjunction with that, we also do outreach throughout the entire New York City area. To work with justice-involved population has been our latest venture. And because we've seen that while they do get some degree of services while they're incarcerated, when they get out, there hasn't been anything at all. And we've picked up on a number of lives and HIV and linked it to care. But it all starts from developing a context of trust between our program and different agencies. It takes a lot of time, a lot of flexibility. And it starts off with service. They want concrete service to be delivered to their populations. But once that gets done, you can build other levels onto that scaffold, which is what we're doing now with this research project. And we're hoping to expand it even further. Kate mentioned other health issues to address. We're hoping to also address cardiovascular disease, which is the main problem, not only for these young people, but as they get into adulthood and beyond. So we can modify their risk-taking behaviors and get them aware of tailored lifestyle behavioral changes. Perhaps we can cut back on hypertension, diabetes, and obesity, and other things. So this is a fabulous population to work with. It's a difficult and challenging population, but having that groundswell of trust is key.
Questions?
So we did not discuss this, even though I work with Kate.
This is not a plan. This is not a plan.
We mentioned at the beginning about the high risk of trauma in this population, and I just was curious if you could speak a little bit to how you see where you see the best opportunities to intervene in that component of the overall risk environment.
So honestly, I need to give that some more thought. That is the next place where I want to go. You cannot ignore the trauma that these youth have experienced and how it influences the way that they move through the world now. as young adults, there's a lot of difficulties that they're managing, and they're not necessarily they don't necessarily have the best skill set to do so. And in part, you can see where trauma has affected them and where their development is sort of arrested. And so I think that there's a lot to be done, but I think that I want to explore more. First of all, so as you can see, typically the trajectory of my work is like spend a lot of time doing kind of correlates work and really understanding what the problem is before sort of developing interventions to do so. And I really need to do that with trauma, just to get a handle on what it looks like for this population and to what degree and how it's influencing, particularly as they're young adults, their current behavior.
Thank you for your wonderful talk. My question relates to Dan's, actually. It seems that the backbone of the intervention is quite cognitive, top-down, and given that these are highly traumatized youth, I was curious as to whether you have any bottom-up or psychosensory interweaves to help them process the material, because I can imagine that some anger gets stirred up when they start to get confronted with
Certainly. It's not necessarily anger so much that we have some facilitators in the room that can speak to this. It's more despondency, I think, that, well, we can't change this. I think it's more what we face. But I think the facilitators do a really good job of being able to, so we don't just sort of I shut my slides off. So obviously we go through the oppression pathway, but we also spend a lot of time thinking about what you can do and how you can change things. And so I think that we spend a lot of time building those skills so that we can offset a little bit of that, those reactions to what's going on. We keep it focused on media, so it's distant enough that we're not speaking about anybody's particular personal experiences. Sure, they come up and they certainly share that, but that's not the main focus of the conversation. And I think that allows us to also manage the high rates and experiences of trauma in the room. But we don't work with them long enough to really unpack it and address it. And so, as I mentioned, that's where I really want to think about what we can do better in ways that we can do that.
Great talk and great program. I was just thinking whether you have considered to go to the state to get some state lines for implementation of all of that, since we just have done that, with transgender people, and have gotten several lines from the state to implement a prison program. So something like that, to now convert it into a state-supported program, because we have On Track New York here with kids who are, have schizophrenic breaks, where the state supports some of them. They're now supporting our transgender program in OMH, in the prisons. So let's talk about that.
Yeah, I had not thought about that, but yes.
Because, that would be great if you've got 2 or 3 state-supported lines and can get into it with that.
Yeah, that would be great.
At that point now, it's fabulous.
That's great.
Right.
I just really appreciate how thoughtfully you've constructed this body of work and how it sort of culminates in this intervention. Given how popular it was, or how acceptable it was to them, how much they wanted more, and given how much youth are connected to social media, or at least connected to one another through their phones, I'm curious what we know about how they might refer other people who are harder to reach than they are. If that's a possibility.
Alexis? No. So Alexis is our social media goddess. Actually, that's not, for this population, and it's an SES thing, I think, it's not actually true. So, and this is another sort of bugaboo of mine as well with respect to kind of mHealth and machine learning, right? There's a lot of investment in this and how we can use this as a tool for intervention. But But what about those folks that don't have this, or don't have it consistently, or they're sharing phones with people? This is not their data, it's mixed data. Or the phone's turned off because they don't have the funds to keep the bill, and we lose track of them all the time. So, and the adage is, only old people such as myself are on Facebook, or, everybody else is, the younger kids are on Instagram or Snapchat. That's not the case with our youth. We're able to find them on Facebook, and that's because with Facebook messaging, you can make calls, call people. And so, there are these things that I think, yes, sort of mainstream, there are ways of utilizing social media to kind of reach, harder populations. I don't necessarily think that's always the case here. And you can't do it consistently. And I think mHealth and machine learning, if we continue to invest a lot of sort of energy in that as a way of developing new and improved health treatment strategies, the health disparities between this population and sort of others are just going to continue to grow. And I think that's really something to be mindful of.
Even without going through the machine, it seems like it's such a popular, they really like the intervention. So I'm curious how you leverage their interest and their ability to speak about it to other people, refer other people.
So they may do, but for the inclusion criteria of the study of the RCT, we need folks to be enrolled at BJI. So they may want to refer their friends, but if they're not enrolled at BJI, then we can't enroll them into the study. So we're not really able to look at that. But I don't know, Bobby, or those of you that are at the courthouse recruiting, how much do we see is there any kind of referral of people that know each other and send them to the program? There is?
It's not too frequent.
How different are the youth that you see from the youth in their network, their peers?
Oh, because they're just involvement versus not?
Yeah.
They're not.
They're not.
Not really. I mean, what happens is the difference is the justice involvement, right? So then that kind of can put them on a trajectory that really.
It's a way to catch them.
Yeah, but but the justice involvement can lead to negative outcomes. As I mentioned, it's once you're justice involved, don't get arrested. It's really hard to get out of the system, and it's on your employment record. We have one of our participants has a felony assault charge where basically she was in a hostel. She found somebody in her room going through her stuff, and she clocked him with a mug, and now has a felony assault on her record, and that she's 22 years old. That is seriously going to limit her future. So I think that's the piece that really sets it apart.
Any other questions?
Yes, can you clone yourself?
Okay, well, we look forward to the next presentation with more results.
Yeah.
This is amazing work. Thank you so much.
Thank you.